Imagine a marathon where the winner is judged by how many cups of water they drank, rather than who crossed the finish line first. Sounds absurd, right? Yet in research, choosing the wrong endpoint can be just as misguided. In pragmatic clinical trials, we must choose endpoints meaningful enough to guide treatment decisions of healthcare providers, patients, and other knowledge users. Before we jump in, let's outline what you'll take away from this module. First, we'll identify the key considerations for selecting endpoints in pragmatic trials. Second, we'll learn how to select outcomes that matter to patients, partners, and other knowledge users. Third, we will explore the use of routinely collected data for capturing outcomes of interest. Fourth, we will also cover how pragmatic trialists address the challenges of capturing specific outcomes, such as hospital admissions and mortality-related events, while maintaining a streamlined process. Finally, we'll discuss strategies to ensure that the outcome assessment remains both practical and rigorous. Okay, so let's start by clarifying some terminology. We often hear the terms outcome and endpoint used interchangeably, but they differ slightly. An outcome refers to the thing you want to measure. For example, that might be blood pressure or a symptom score. An endpoint refers to how you analyze that outcome. For example, that might be how the blood pressure changes from baseline to 6 months. When selecting trial outcomes and endpoints, pragmatic trials aim to strike a balance between what is ideal and feasible. Of course, the research question and trial intent always drive what we want to measure. At the same time, we need to ask whether it is possible to capture this measure in everyday practice without requiring a research SWAT team. One hallmark of pragmatic trials is a focus on meaningful clinical outcomes and the endpoints we choose to measure them. These are the metrics that make patients and partners nod and say, yes, that's what we care about. For instance, researchers or regulators might be interested in knowing that a new drug lowers a specific lab value. But what if patients don't feel any better or have better health for a longer period as a result? In pragmatic trials, we lean toward outcomes like survival, symptom improvement, functional status, and quality of life that can inform healthcare decisions. When choosing pragmatic endpoints, the key is to prioritize practicality over perfection. Ideal pragmatic endpoints are naturally embedded in routine clinical care, leveraging data that's already being collected. This ensures that measurement is low burden, without requiring extra visits, specialized tests, or disrupting workflows. Pragmatic endpoints work best when they're objectively measurable, especially in open-label studies where subjective assessment can introduce bias. Equally important is ensuring participants are followed long enough for the outcomes of interest to manifest. Having a premature cutoff can miss effects or distort interpretation of treatment effects. Again, a fundamental principle here is to minimize interference with routine care. However, sometimes you'll need outcomes that aren't captured through everyday clinical records, like a patient's pain level on a Likert scale following an intervention. In these instances, collaborate closely with participating sites and your partners to train local staff in straightforward, standardized assessment techniques. If there's a risk of bias, consider blinding evaluators to the participant's treatment group. Consistency is essential, so ensure all sites clearly agree on what qualifies as an outcome and how it is measured. Another consideration is to establish mechanisms for continuing data collection, even if participants deviate from the study protocol. This commitment aligns with the intention to treat principle, preserving the integrity of your analysis. If you have the necessary ethical and institutional approvals, patients who stop the intervention can sometimes have their outcomes tracked through claims data. Participants can also provide consent separately for randomization, receiving the intervention, and data collection. Work closely with your research ethics office to put in place mechanisms that allow continued data collection, even if a participant withdraws consent for other parts of the trial, so long as they maintain consent for data collection. So, engage healthcare partners early when choosing and refining endpoints. Clinic teams, IT specialists, and patients can offer invaluable insights into what matters and is feasible in practice. Early collaboration ensures that your outcome measures are both scientifically sound and practically achievable. There are many sources that can be leveraged for capturing comprehensive clinical outcomes. To name a few, these sources may include disease-specific registries, emergency department and hospital records, electronic medical records-based networks, biobanks, and trial-specific databases. In Canada, organizations like CIHI, HDRN Canada, through its Data Access Support Hub, or DASH, Statistics Canada, and provincial repositories and research networks coordinate access to these rich data assets. Leveraging these data sources in pragmatic trials demands planning around consent, privacy-preserving linkages, and governance approvals through data access committees. For example, it can take several months to over a year to complete ethics and privacy approvals, negotiate data sharing agreements, establish linkages, identify variables that can be captured in these data sources, develop algorithms to capture these variables, access, clean, analyze, and report the data. Therefore, start early and anticipate delays. There are many advantages to using routinely collected data. First, access to these data is relatively inexpensive compared to traditional data collection because there isn't a need for dedicated research staff or elaborate case report forms. Second, because the data come from care that would happen anyway, patients aren't asked to return for extra tests or visits, and providers aren't required to do anything beyond their usual practice. As a result, the trial imposes minimal additional burden and the data reflect real-world clinical workflows. That said, if an event isn't documented, it effectively didn't happen. For example, a clinician might omit an entry in the chart, or a patient's issue may never generate a health system interaction because they managed it at home. So, proactively identify common blind spots, like mild events, incomplete documentation, or care received outside your data network. Now let's assume you've chosen an outcome and plan to rely on routinely collected data. Here are some considerations. First, consider whether the outcome typically leads a patient to seek care or interact with the healthcare system. If so, consider whether that health system interaction is a high or low resource intensity event. High resource intensity events, such as those requiring hospital admission, typically leave multiple data footprints, whereas low resource intensity outcomes may be managed with over-the-counter medication and may not appear in your data sources. Whenever possible, leverage validated algorithms with robust operating characteristics to capture your outcomes, and, where feasible, combine information from multiple sources. For example, a stroke might be reliably identified through a combination of diagnosis codes, procedure codes, such as MRI of the head, and possibly even pharmacy fills for clot-busting medications. Regardless of your approach, engage directly with the professionals responsible for documenting or transcribing these events into your data sources. For example, administrative medical coders converting hospital discharge forms into ICD-10 diagnostic or billing codes follow strict standardized protocols. Understanding their processes can help confirm the completeness and accuracy of outcome capture. Even the most resource-intensive events, such as a hospital admission with a myocardial infarction, can be missed due to poor documentation or administrative errors. Hospital encounters are pragmatic-friendly endpoints because they're routinely documented. Begin by deciding exactly what qualifies. For example, are you interested in any emergency department visits or hospital admissions? Or are you looking for specific events like a myocardial infarction or ischemic stroke? If so, do you want the record to reflect what prompted the hospital encounter? For example, the chief complaint or admission reason, or the most responsible diagnosis coded for that encounter? Beyond the encounter, are you interested in the length of stay? If so, how do you record the length of stay where a patient is hospitalized shortly after midnight and released shortly before midnight on the same day? Is the length of stay 0 days or 1 day? These are just a few of the many factors to consider. Your definition must strike a balance between clinical relevance and how coders actually record the events of interest. A definition that is too narrow risks missing events, while one that is too broad dilutes its meaning. Finally, align your endpoint definition with what your data can capture. Local health records give rich detail for in-network care but miss out-of-network events. If you're relying on administrative data to fill those gaps, specify how you'll reconcile the systematic differences in content, completeness, and coding between the in-network and out-of-network sources. Death is an appealing endpoint for its apparent clarity, but accurately capturing it often requires layering sources. Start with the gold standard, national or provincial vital statistics, which offer adjudicated cause-specific mortality. Because those files can lag by 12 months or more, build the delay into your analysis timeline once the trial follow-up ends. For example, suppose we are interested in capturing cardiovascular-related deaths. We could begin by using provincial or national vital statistics files. Again, this information can be behind by 12 months or more, so it might only capture events in the early follow-up window. To bridge the gap, we could use in-hospital deaths that carry a discharge, with a cardiovascular-related event as the most responsible diagnosis. However, even these datasets can be lagging by 3 to 6 months. To capture community deaths that reach hospital doors, we could also consider emergency department records with dead-on-arrival disposition and cardiovascular-related diagnostic codes. Even with 3 feeds, events from the last 3 to 6 months can slip through, and any cardiovascular deaths occurring entirely outside hospital walls remain invisible until the vital statistics update. It may be worthwhile to use historical data to estimate the missing fraction during the trial period and then run sensitivity analyses to gain an understanding of how these missed events might influence the trial results. Again, align your analysis timeline with each dataset's release dates and start early with plans for securing data linkages and getting the appropriate data access approvals. Beyond routinely collected data, it may be necessary to capture patient-reported outcomes or non-traditional data like those available by using wearable technology. The goal is to minimize the burden on providers and participants as much as possible. So, work with partners to consider which data are necessary, the tools or resources needed, who is responsible for collecting the data, and the frequency of collections. Mobile tools like fitness trackers or wireless blood pressure cuffs can provide rich, real-world data, but only if they're easy to use and widely adopted. So, anticipate a potential for a high amount of missingness or even technological failures. So, any novel measures, whether self-reported or device-generated, must be linked to clinical outcomes, and it's prudent to have a backup endpoint in case the method fails. Next, let's consider composite outcomes, defined as a single endpoint resulting from the occurrence of any one of multiple component events that together represent the same underlying risk. Composite outcomes are often used in pragmatic trials because their use may allow for the capture of sufficient events to detect a difference between treatments without conducting a massive and expensive trial. This assumption is obviously made with the understanding that the intervention has a reasonably similar effect across its components. That's why you shouldn't lump together outcomes like minor chest pain and death, because 1, the biological or causal pathway through which the intervention would influence them is unlikely to be the same. And 2, their baseline incidences differ dramatically. Minor chest pain is far more frequent than death. So the composite would be dominated by the more common, less severe event and obscure the true effect on the others. The final type of endpoint we'll discuss is the desirability of outcome ranking, commonly referred to as DOOR. Think of DOOR as a benefit-risk dashboard rolled into a single ordinal scale. Instead of reporting separate efficacy and safety endpoints, we rank each patient based on the overall desirability of their outcomes. We do this by first creating a clinically meaningful hierarchy. This hierarchy would be pre-specified in the protocol, with input from partners, so the ranking reflects real-world values. For example, this might prioritize survival at the top, followed by symptom relief, avoiding complications, and any other factors that matter to patients. Finally, report the DOOR probability, which is the chance that a randomly selected participant in the intervention has a better rank than a participant in the control group. An approach that uses desirability of outcome ranking can enable pragmatic trials to adopt a patient-centric approach for evaluating the intervention being tested. So, providers' and patients' perspectives must be considered in how different outcomes affect the overall ranking, taking into account both benefits and harms. This endpoint can be both globally comprehensive, encompassing survival, symptoms, and safety, yet granular enough to reveal which ranks drive the difference. It can also account for competing risks that can distort the interpretation of traditional binary endpoints, providing a clearer picture of the trade-offs between different treatment options. By weighing benefits against harm, DOOR offers a richer narrative than separate binary endpoints. The framework is also adaptable, so it can allow a multidisciplinary panel to tailor the ranks for sepsis-related outcomes today and cardiovascular-related outcomes tomorrow. Here's what a DOOR endpoint might look like in practice for a cardiovascular-related trial. In this example, the overall clinical outcome has 8 mutually exclusive hierarchical levels in descending order of desirability. At the end of follow-up, a patient with a rank 1 would be alive, have no cardiovascular-related events, and report an excellent health-related quality of life. On the other extreme, a patient with rank 8 would have experienced a cardiovascular-related death during the trial period. Ranks between 2 and 4 capture survivors without events, but with progressively lower health-related quality of life. Ranks 5 to 7 include non-fatal events like hospital admission with myocardial infarction, heart failure, and stroke, ordered by severity and accompanying health-related quality of life. During analysis, each patient is slotted into the worst rank they reach, and ties can be broken by event timing. This schema blends hard clinical outcomes with patient-reported experience, giving patients and partners a single, ordered measure of overall desirability. Sensitivity analyses can test alternative rankings, but the core principle remains: one rank, full patient story. As we conclude, let's review some key considerations for specifying outcomes and endpoints in pragmatic trials. Pick outcomes that matter to patients, providers, and knowledge users. Things like survival, symptom relief, hospital visit, or length of stay, or a composite type outcome like the desirability of outcome ranking. Ensure you can measure the chosen endpoint without turning the trial into a research circus. Where possible, use data collected as part of routine care or develop collection tools that minimize the burden of data collection on participants and providers. Familiarize yourself with available data sources and, when possible, leverage multiple sources to capture events that any one source might miss. Finally, and this can't be stressed enough, don't design trial endpoints in a bubble. Talk to clinical trial end users and the individuals who collect the data, making adjustments as needed.